Hi, I'm Dr. Twasim and welcome to my derm classes. Today's lecture is on history taking in psoriasis. So this was one of the requested lectures. So there are different types of psoriasis and the differentials for each type differs. So I'll be mainly sticking to chronic plaque psoriasis in this lecture. Just let me know if you need more lectures on other types of psoriasis. So in general, we need to take history under the following headings: Presning complaint, history of Presning complaint, past medical history, family history, personal and social history. So let's start with the Presning. So the Presning complaints can be red scaly patches in the body. They can present with nail changes like nail pitting or dystrophic nails. Patient can also present with problems of arthritis. They can also present with pustular lesions, which is very painful. That happens in pustular psoriasis. So let's delve into history. So delving into the history of Presning complaint, you need to ask in detail about the Presning complaint. You need to ask about the aggravating and relieving factors. You also need to ask about any associated features of your suspected diagnosis. You also need to rule out the other differential diagnosis that you have in mind. So let's see in detail. So you can ask about the onset, the progression, the site of the present history. For example, when it comes to the chronic plaque psoriasis, the patients can complain that it started as a small red scaly lesion, which gradually evolved to larger plaques. And they can also say they noticed in sites such as elbows and knees, the extensors of the arms and legs, the scalp, or the trunk. Then comes to the exaggerating and the relieving factors. The relieving factors can be some of the topical treatments that they have used, like corticosteroids. And when it comes to the exaggerating factors, there are certain things that you need to consider. One is basically the infections. So it's most commonly streptococcal infections. So you can ask about any history of throat infection. You can ask about any cellulitis. You can ask about any abscess. You can also ask about any recent intake of drugs. The most important drugs that causes psoriasis is or precipitate psoriasis is mainly lithium. Then it can be corticosteroids, sudden withdrawal of the corticosteroids, or it can be the antimalarials or beta blockers. Then comes another factor, which is the psychological stress. You can ask about the workplace or the personal life stresses which might have precipitated. Then another event is in females. You can ask about pregnancy. So in pregnancy, sometimes tend to bring down psoriasis, but in some cases, it seems to exaggerate psoriasis. So you need to ask about that as well. If it's pustular psoriasis, you need to also consider clinical condition of hypocalcemia, which might be a precipitating event. And next, you need to ask about the associated features. So one, as I've already discussed, it's the nails. So the nails, they can complain that it's become increasingly difficult for them to cut their nails, which is basically because of thickening of the nail plate. Then it can be pitting, or they can also complain about detachment of the nail, which we call as onychomedesis. So these can be some of the complaints which they present. So next is about the arthritis. So there are several types of arthritis that is associated in psoriasis. There are 5 different types, which are rheumatoid arthritis-like, ankylosing spondylitis-like. Then we have arthritis mutilans. Then we have oligoarthritis and dactylitis. So the classical feature is that they are inflammatory type of arthritis. So in inflammatory type of arthritis, generally the patient will have more pain in the morning. And once the patient starts the activity, generally what happens is that the pain comes down. So this is something that you can ask in the history just to come to a diagnosis of inflammatory arthritis. Then next comes the differential diagnosis. So in chronic plaque psoriasis, the main differential that you need to consider will be eczema as well as tinea. So if you're considering the eczema, then you need to ask about the other aspects of the history, like any family history of atopy in case you're considering atopic dermatitis, or personal history of atopy as well. You can also ask history of intense itching, which generally occurs in eczema. And in the acute phase, generally they will have oozing. So these are the differentiating features from psoriasis. In psoriasis, there might be itching, but which is not very intense as in eczema. And the next one is tinea. So when it comes to the tinea, you can ask the patient about, again, the sites of onset. Generally, tinea occurs in the flexures. It can also occur in other sites. Again, it's associated with intense itching. You can also ask if any family members have similar lesions because it's a contagious one. So these are some of the points that you need to keep in mind while considering history of pressing complaint. So let's go on to the past medical history. So in the past medical history, you need to ask about the drugs they have been taking, as discussed before, and you can also ask about the drugs that they took for psoriasis. For example, any corticosteroids that's been taken systemically or topically, which is suddenly stopped, can result in a flare of psoriasis. You can also ask about any chronic kidney disease. Why? Because this can cause vitamin D deficiency or hypocalcemia, which tends to precipitate pustular psoriasis, or even vitamin D tend to resolve a bit the chronic plaque psoriasis. So you can ask about that. You can also ask about any parathyroid surgeries because that can also result in hypocalcemia. Now, coming to the family history and what you need to ask. So psoriasis have a tendency to occur in families, and there are certain genes that's been associated. So following certain percentages that signifies the importance of familial occurrence of psoriasis. So generally, the chances of occurrence of psoriasis is more if both of the parents have psoriasis. And then there are certain genes that's associated with psoriasis, which is SOR1 to 9, HLA-CW6. HLA-B27 has been found associated with psoriatic arthritis, though it's not very specific. Coming to the personal history, what you need to ask. You need to ask about alcoholism and smoking because this can tend to increase psoriasis. Again, obesity. So obesity has been seen to be a consequence of psoriasis as well, as metabolic syndrome is seen to be a consequence of psoriasis. The next one is you can ask about the work, the type of work they're doing, which will help us to delineate the psychological stresses that the patient might have. Next is you also need to assess the quality of life of the patient. This is very important when you're considering the treatments. You might need to change your treatment regimen according to how much the quality of life is affected. So with this, I think the history's come to a conclusion. Thank you so much for listening. I hope this helped. In case you have any doubts, just let me know. And let me also know if you need further classes on other types of psoriasis, like pustular psoriasis, gutted psoriasis, flexural psoriasis. So I hope this helps. Thank you so much.